The presence of germline predisposition is important because sometimes what happened in the past when we didn't know that these germline mutation might be present, or we were not able to identify them because of like the limits of molecular tools in the past decades, we were witnessing a particular case of leukemia or relapse after transplant, which is called donor cell leukemias. This is only 2 to 5% of all relapse after allogenic transplant, but about 80% of the time this is probably due by the presence of a germline mutation that inadvertently is passed along with the graft. Now that we are able to identify this mutation, we know that the majority are those genes that perhaps have not extra hematological phenotypes and therefore are difficult to identify in donors if you don't know anything about the family history of the donor or you didn't identify this with the molecular tools. Therefore, we, together with the Chronic Malignancy Working Party of the EBMT, in one of the efforts of the harmonization guidelines, try to tackle this problem. After a meeting in Berlin where we gathered together, we decided and we to address what we can do for the best clinical management of donor cell leukemias, and these guidelines are soon to be published in the Lancet Hematology. And today we have the session where we will discuss how to best diagnose and approach this patient. It's imperative when we have a donor cell leukemia to assess the molecular profile of this patient, because sometimes not only is important to understand if there's a germline predisposition and therefore go back to the donor, if it's a relative, or especially if it's like an unrelated donor, to understand if we can reach out to the donor himself or herself. But also to understand if there are like molecular targets that we can use for the donor cell leukemia that we have in front of us, and perhaps bridge the patient to another second allogenic transplant, which in most of the case is the only curative option for these patients. But it's obviously tricky because these patients are already being allograft, and therefore a second allograft is decided upon a specific indication like age, the performance status of the patient, the previous iatrogenic burden and chemotherapy exposure. So a lot of factors goes into that decision.